Welcome to my second COVID-19 presentation. I'm Dr. Michael LeVasseur, and today is Monday, May 18th, 2020. I'm an infectious disease epidemiologist and visiting assistant professor in the Department of Epidemiology and Biostatistics at Drexel University's Dornsife School of Public Health in its always sunny Philadelphia. I'm primarily interested in infectious disease and both gender and sexual minority health disparities. I've been following the SARS-CoV-2 epidemic since late December, and I'm pleased to present some of what I've learned about this virus to you as a public service. But before I do, I need to make a few disclaimers. First, please don't trust a YouTube video, including this one. Of late, there have been many videos surfacing from seeming experts who are espousing very bad science and not providing a whole lot of citations. Throughout this video, I'll be citing my sources in the bottom of each slide. If I can figure out how to make YouTube do my bidding, I'll link to each of these references throughout so you can check them out for yourselves. Much of the research I'll be presenting has not yet been through the peer review process. Since January, preprint servers have had more than 1,400 publications uploaded without peer review. While this is an important way to disseminate information quickly, the results should be considered to not yet have been vetted by the scientific community. As for me, I'm not a physician, virologist, immunologist, or politician. I'm an academic and an epidemiologist. While I have training in molecular biology, I am by no means an expert and my interpretations may not be valid. Finally, I need to mention that I am not paid for this work. I do this freely to provide information to my family and friends near and far. If you're viewing this and you don't know me personally, chances are one of them shared the video and thought it's credible. I've received offers to do consulting work during this pandemic and have turned them all down to make certain that I do not appear biased. This will be a lengthy presentation where I'll cover a number of topics. A few weeks ago, I asked my Facebook friends to ask me their questions about this disease so that I could better educate them on what they need to know for their families and their communities. Throughout this presentation, you'll see teal boxes pop up with mostly unedited questions that have been asked. I will provide links to each of these sections of this presentation so you can skip around as needed. We will begin with a discussion on the epidemiology of COVID-19. Epidemiology is the basic science of population health and concerns itself with the spread of disease in populations. If a physician is concerned with the health of individuals, an epidemiologist is concerned with the health of communities. In the United States, we conduct syndromic surveillance on influenza-like illness, or ILI. Many people have questioned how COVID-19 compares to other seasonal respiratory infections. I've gathered data on deaths from ILI, including influenza, pneumonia, and COVID-19, from the Center for Disease Control and Prevention. I use data from the 2018-2019 season and the 2019-2020 season. CDC uses surveillance weeks to compare to previous years, with weeks 5 through 9 approximating February, 10 through 14 approximating March, and 15 through 17 approximating through late April. Data for the end of April were not available at the time of this analysis. I also present the total number of deaths from all causes. These data are more up to date for 2018-2019 season than the current season due to reporting delays, but these represent an undercount in the more recent season. Compared to the previous season, influenza deaths were up by 22.7% in February and 9.1% in March, and 20.3% in April. Pneumonia deaths were up 10.6% and 10% in March and April, but down by 5.5% in February. Overall, in April, there were 12.7% more deaths in 2020 compared to 2019. When we explore this as a function of the percent of all deaths in each month, the rate of death for influenza and pneumonia are similar across months, with a higher proportion of deaths caused by pneumonia than influenza. The data from March suggest a slightly higher proportion of pneumonia deaths than the previous year, 7.2% compared to 6.6%. However, in April, 18.3% of all reported deaths were caused by COVID-19. Some people have speculated that non-COVID-19 deaths are being reported as COVID deaths, and others will say that we're undercounting COVID-19 deaths. These will vary by jurisdiction, but by next year these should be more stable estimates with similar case definitions. Importantly, individuals can have multiple causes of death listed on their death certificate, and these can include influenza, pneumonia, and COVID-19. As such, these data are inclusive of individuals with multiple respiratory illness causes of death. Finally, I pulled these data 2 weeks ago, so numbers have most certainly changed since then, but the data are publicly available at the links provided. So how does this ILI season compare to past years? Here I've pulled data from the past 4 influenza seasons to show you the number of ILA patients reporting to emergency departments in each season. This green area represents the number of patients reporting to emergency departments with influenza-like symptoms. In each season, you can see that these increase substantially in the winter months and decrease in the springtime. Each season has different peaks which correspond to the typical flu strain. The peach area represents the number of individuals who have tested positive for any of the 4 strains of seasonal influenza. These track along with the peaks of all ILI symptoms, which is why we can use the ILI symptom as a predictor of the flu season. What interests me the most is this area here. It isn't unheard of for there to be more than 1 peak in an influenza season. However, this year has 3 peaks in ILI surveillance, but only 2 peaks in the number of positive influenza tests. This occurs around surveillance week 10, which corresponds with late February or early March. We can also explore this by the percent of all emergency department visits that were for ILI, where we will see this triple peak right here. Or we can explore it as the percent of all ILI individuals who were tested for influenza that were positive, which only has 2 peaks. This 3rd peak in late February most likely represents COVID-19, and is why I find it difficult to believe that this was circulating broadly in our communities before late January. While the total number of ILI cases in the emergency department were larger for this season than previous seasons, we'd have expected to see more pneumonia-related deaths earlier on if COVID-19 were spreading in the community prior to our current estimates. It isn't clear why men are more likely to die from COVID-19 than women, but there are a number of theories, including behavioral risks, such as men being more likely to smoke, or biological risks, such as men having higher incidence of cardiovascular disease. However, according to data from New York City, compared to women, men are 1.2 times more likely to be cases, 1.5 times as likely to be hospitalized, and 1.7 times as likely to die. The overwhelming majority of individuals with COVID-19 in China were infected in some sort of indoor venue, with most people, 80% of which, likely infected in the home. In this large study of all cases throughout China, excluding the Hubei epicenter where contact tracing was more difficult, researchers only found 1 instance of probable outdoor transmission. The authors wrote, "Our study does not rule out outdoor transmission of the virus. However, among our 7,324 identified cases in China with sufficient descriptions, only 1 outdoor outbreak involving 2 cases occurred in a village in Henan. A 27-year-old man who had a conversation outdoors with an individual who had returned from Wuhan on the 25th of January and had the onset of symptoms on the 1st of February. It is still incredibly difficult to tell precisely where we are in this epidemic nationwide. Largely, this is due to our inability to adequately test people. Cities are testing at different rates per capita and have different priorities in who gets tested. Although testing has ramped up substantially since mid-April when I put this together, and many cities and states are offering more expanded testing, we still don't have reliable data on how many people have been infected. Even at the state level, it's difficult to determine how much better the situation may be now compared to a few weeks ago. Therefore, testing and the total number of cases are a poor indicator of the population-level disease burden. We can instead look at the number of individuals hospitalized for COVID-19 to provide a better estimate, but this excludes mild, asymptomatic, or pre-symptomatic cases, which are likely driving this epidemic. The fog we were in a month ago is starting to clear, but visibility is still low across the country. Related to that, we haven't been able to adequately do any contact tracing. On May 6th, New York Governor Cuomo reported on some statistics they were able to put together by asking newly hospitalized patients over a course of 3 days where they were admitted from, what type of transportation they've been using, and what their employment status was. Surprisingly, the overwhelming majority of new admissions were from the home, among people who are working from home or unemployed. These results raise a lot of questions about how compliant individuals have been with stay-at-home orders and where community transmission is occurring. In the coming weeks, as states expand their contact tracing efforts, we'll have more reliable data to determine the best policies moving forward. Several people have asked me about possible mutations and what it would mean for the course of the pandemic. This isn't something I'm particularly concerned about, but the media has run with a story about possible new strain of COVID-19 that is more infectious. This paper has not been formally peer-reviewed, although it has garnered a lot of discussion in the scientific community. This paper, which was uploaded on April 30th, describes a single point mutation from aspartic acid to glycine at the 614th amino acid residue. The authors argue that this mutant is more infectious in some way based on its spread. They offer 3 possible mechanisms for increased evolutionary fitness. 1, that it has a stronger affinity for the ACE2 cellular receptor. 2, that there's some sort of antibody-dependent enhancement, wherein an antibody binding to the virus actually increases its ability to infect cells. And 3, simple antigenic drift, where by chance alone this mutant is more successful. The authors pontificate that if the D614D mutation in SARS-CoV-2 was impacting neutralizing antibody sensitivity, as well as, or instead of, the antibody-dependent enhancement activity observed in the SARS-CoV study, D614G could also be mediating escape that makes individuals susceptible to a secondary infection. I miss molecular biology, so bear with me as I try to explain this a bit further. The spike protein on SARS-CoV-2 is what gives it its name. It's this spiky protrusion that makes it look like the corona of the sun. Spike is the viral receptor consisting of two subunits, S1 and S2. In this region of spike is the receptor binding domain, or RBD, which binds to the ACE2 receptor and allows the virus to infect the cell. The authors argue that this D614 amino acid residue exists in this RBD region, and therefore any mutation in it could potentially increase its ability to bind to the cellular receptor ACE2. Here, these authors compare sequences between the D614 and the G614. Up here, the G614, the mutant version, is in blue, and the orange is the original version. They show that the epidemic in Sheffield, England is the same as the course documented throughout the globe, with G614 overtaking D614 as the dominant form of SARS-CoV-2, which is sort of the central thesis of why they think this is more evolutionarily fit. They found no statistical difference between age groups among those who were infected with one strain versus the other. And they also point out that the mutant strain was not statistically associated with an increase in, or decrease in hospitalization status, meaning that the pathogenesis and virulence of both of these versions are similar. They did, however, point out that there was an association with fewer rounds of PCR required for detection, which suggests potentially that people with the G614 virus, this mutant strain they're referring to, had higher viral loads, which could potentially mean increased infectivity. A lot of this is still unknown, and the fact that CT of 24.9 in the original versus a CT of 23.1, I'm not sure how much of an impact that those cycle thresholds or the viral load that they represent will have a huge difference in the transmission dynamics. In fact, I'm not the only one that isn't convinced. There was a publication in the New York Times on May 6th that points out that no evidence exists yet that it is evolving in a way that has made it more contagious or more deadly. And there is no new strain because a single mutation does not imply that it's diverged into clearly distinct forms, which is what the definition of a strain is. Further, mutations happen all the time in viruses, and usually at very calculated rates. Just because a mutation becomes more common doesn't mean that it's altered function in any way, shape, or form. None of the critics of this paper ruled out the possibility that a mutation could arise that could make the virus more transmissible, and it's possible that D614G has some sort of edge, but it will take much more evidence to rule out other explanations. The past few months have been a whirlwind, and it has been difficult to keep up to date with all of the new information about this disease, but what follows is a discussion of some of the clinical characteristics. We're not yet certain what the infectious dose of this virus is. That is to say, how much virus is needed before someone becomes infected. We do know that viral load is highest early on in the infection than later. Among 17 symptomatic patients and one asymptomatic patient, peak viral load lasted for 4 to 6 days and diminished thereafter. Here CT stands for cycle threshold, which I'll discuss later, but the fewer cycles that PCR has to go through to detect the virus, the higher the concentration is in the sample. The CT value for the one asymptomatic patient in the study was similar to those who were symptomatic, which suggests that there is no difference in the infectivity of symptomatic versus asymptomatic or pre-symptomatic individuals. This information is vital to our contact tracing efforts and implies that we need to be identifying contacts of individuals 2 to 3 days prior to symptom onset. Another question is, how long are people infectious for? We don't have good data on this either. In this study of 33 patients, researchers collected throat swabs, sputum samples, and stool samples over the course of infection. Patients had detectable levels of virus for 18.5 days in throat swabs, 22 days from sputum samples, and 17 days from stool samples, but it's not clear whether all of these samples contain infectious virus. This study of 67 patients, 43% of whom had severe symptoms, tells a similar story. However, they were able to differentiate between severe and mild or moderate symptoms. While the CT was similar early on in the infection between these two groups, those with more severe symptoms had detectable virus for longer in each of the specimen types compared to those with mild or moderate symptoms. Again, we don't know what this means for infectivity, but for the time being it's safe to assume that people are infectious for a long period of time, but that peak infectiousness lasts 4 to 6 days and begins early on in the infection. One of the more severe complications related to COVID-19 is what some physicians have referred to as a storm of blood clots. Between 20 and 30% of critically ill patients appear to have these blood clots, and blood thinners don't seem to be terribly effective at preventing them. These clots have been observed in both large and small vessels. Microclots may further restrict the flow of oxygenated blood in the lungs, further impacting disease severity. Two hypotheses have been put forward to explain this. The first is that endothelial cells in the blood vessels themselves are becoming infected, leading to an increase in clots. The second is that a part of the innate immune response, called the complement system, is being activated, causing an increase in these clots. A retrospective study of the outbreak in Wuhan suggests that among 5% of hospitalized patients had cardiac events, but this happened to be among older populations, with the youngest stroke victims being 55 years of age. There was previous evidence of stroke from the first SARS outbreak in 2003-2004 in Singapore. However, the association between large vessel stroke and COVID-19 in younger patients requires further investigation. This article, published in the New England Journal of Medicine in late April, describes 5 young patients aged 33 to 49 in New York City who presented with large vessel stroke symptoms, all 5 of whom tested positive for SARS-CoV-2. An analysis of out-of-hospital cardiac arrest in 4 of the hardest hit regions of Italy suggests a strong correlation with SARS-CoV-2 infection in the community. The authors of the study suggest that 77% of the increase in out-of-hospital cardiac events can be explained by COVID-19 infection. In this panel A over here, you see all of the cases of out-of-hospital cardiac arrest across all these 4 regions down here. The blue bars represent data from 2020, the orange represents data from 2019. And just looking at those two, you can see that there's an increase in the overall number of cases per 100,000 population. This red bar here represents the total number of COVID-19 positive individuals in the population. And there is this monotonic increase between the number of people in the population with the virus and an increase in the number of cardiac events. It's not clear what this relationship is, but at least statistically it looks like there's a correlation between the two. But remember, correlation does not equal causation. Another curious symptom is the loss of smell and taste, known as anosmia and ageusia. One small study of 130 patients suggested that 64% of patients reported this symptom, although 34% of these patients also reported a blocked nose, which could be related. Anosmia was more common among women, with 72% of women reporting this symptom compared to only 56% of men. One friend asked, "A news story all over my social media feed is about the Long Island reports of a dozen children with Kawasaki-like inflammatory complications that may be linked to COVID infections. I can't tell if this isn't meaningful or not, and worse, I can't tell how to make that determination." This condition is now known as pediatric multisystem inflammatory syndrome, or PIMS, and it's potentially associated with coronavirus disease. We have a case definition for it, which includes a child presenting with persistent fever, inflammation, and evidence of single or multi-organ dysfunction. This may include children meeting full or partial criteria for Kawasaki disease. Physicians are encouraged to exclude patients with any other known microbial cause, including bacterial sepsis, staphylococcal or streptococcal shock syndrome, and infections associated with myocarditis such as enterovirus. Clinicians should not delay seeking expert advice while waiting for results of these investigations. Throughout New York State, there have been 119 possible cases, with 7 confirmed cases in New Jersey and 16 other states reporting cases. It was first reported by doctors in Britain, Italy, and Spain in late April, and appears to particularly hit children aged 2 to 6, and this occurs approximately 4 to 6 weeks after the initial exposure to SARS-CoV-2. Treatment includes intravenous immunoglobulin and steroids to reduce the body's immune response that causes the inflammatory syndrome, but children are also being given other medications to protect the heart, kidneys, and other organs. Now we move on to the topic of vaccines. It's something that everyone seems to want to talk about except me. There are numerous types of vaccines, ranging from whole pathogen vaccines you're probably most familiar with, to more recent vaccines such as the subunit or nucleic acid vaccines. When most people think of vaccines, they think of the common childhood vaccines, which are often live attenuated or inactivated. But many of the more recent advances in vaccine development have focused on subunit vaccines. According to the World Health Organization, there are 5 COVID-19 candidate vaccines that are in early phase trials. 2 of these are inactivated whole pathogen vaccines, and the other 3 are nucleic acid-based vaccines. Among the clinical trials registered in the United States' clinicaltrials.gov, several early-stage vaccines have been registered with varying completion dates, ranging from June of this year to July of 2023. There are also some trials exploring the efficacy of the BCG vaccine against COVID-19. BCG is a vaccine against tuberculosis that's been used in different parts of the world. This has been proposed as a potential candidate due to its immunomodulating effects, and that countries with high vaccination rates against BCG appear to be doing better against COVID-19. Finally, there are a number of trials exploring the effects of convalescent plasma that we should expect results from soon, potentially by the end of the summer. The timeline for a vaccine is not easy to predict. It depends on how effective the vaccine is and how easy it is to manufacture. We don't want to speed through the discovery and safety part of this process because that could lead to disastrous outcomes. However, the United States is prepared to begin manufacturing of candidate vaccines before the results of phase 3 trials come out. This means that we'll likely waste a lot of money manufacturing things that do not work, but in the event that even one of them does, it means that we can deploy large quantities of it more rapidly if it proves safe and effective. Sadly, many Americans wouldn't get the vaccine even if it was safe and effective. In a Gallup poll conducted in late December of last year, 11% of Americans polled reported that vaccines are more dangerous than the diseases that they cause. Republicans and independents were more likely to believe that vaccines are dangerous than did Democrats, and there were substantial differences between those with less education and those with children. A Yahoo News and YouGov poll of unknown generalizability showed that only 55% of Americans were willing to get the vaccine, with 19% refusing outright and an additional 26% being uncertain. Considering that we'd need between 60 and 80% of the population vaccinated to develop the level of herd immunity needed to prevent continued community spread, I'm not sure how effective an intervention this will be. One friend wants some sort of assurance that there will be a vaccine. I'm not convinced that there will be, and even if there were one that was safe and broadly effective, I'm not convinced that we'd have uptake at levels that would prevent further spread of the disease. I hope I'm wrong, but with a respiratory pathogen, we shouldn't be putting all of our eggs in any single basket. We need to increase our contact tracing and testing capabilities, fund research on treatment, and also look at vaccines. Hopefully together, these interventions will have a substantial impact on the disease burden. To add to the uncertainty around vaccine development is the question of immunity. Does this infection confer immunity at all? And if so, how long does it last? Viral pathogens tend to result in the generation of 2 types of antibodies, IgM and IgG. IgM are large antibodies that appear early on in the immune response. IgG, in comparison, are much smaller but are produced in larger quantities. IgG are capable of becoming neutralizing antibodies, which result in the destruction of the virus. It is these neutralizing antibodies that we're most interested in seeing. It takes up to 10 days for the body to produce detectable levels of antibodies for SARS-CoV-2. But not everyone develops an antibody response. More severe cases tend to have a stronger antibody response, but antibody response itself does not predict clinical improvement. Among those who develop neutralizing antibodies, they appear to last for at least 40 days. With SARS-CoV-1, antibodies remained high for 4 to 5 months, but slowly declined over the course of 2 years, and they lasted for up to 34 months with MERS-CoV. Among 4 rhesus macaques who were infected with SARS-CoV-2, none of them became reinfected when they were rechallenged with the virus 28 days after the initial infection. However, reinfection does occur with other human coronaviruses. And finally, a positive antibody test does not mean that someone has immunity. It's just way too early to tell. Critically ill patients tend to have a higher antibody response than non-critically individuals, but the onset of antibody production seems to be similar between the 2 groups, which you can tell over here in panel C, with the blue line indicating the non-critical individuals and the green line indicating the critical levels, and these representing the total number of antibodies between those 2 groups at different points in time. Here, panel A represents 6 patients with mild or moderate disease, and panel B represents 3 patients with severe disease. The purple lines represent viral RNA, the red lines total antibody, the blue lines IgM, and the green lines IgG. The purple zone up top represents the area of undetectable viral RNA, and the blue area on the bottom represents the antibody seronegative zone. dotted purple lines represent the date a patient first had an undetectable viral RNA test, and the dotted red line is the first time a patient had detectable antibody. Considering that the antibody response takes an average of 10 days to appear, and that detectable levels of RNA can last for 18 to 22 days, I think it's best to imagine that individuals who have antibodies during this period are potentially still infectious. Of course, if you're only getting an antibody test, that doesn't tell you when you were infected. I don't think we have enough information to know for sure how long people are infectious. The authors of a recent JAMA review on the topic of immune response state, in summary, existing limited data on antibody responses to SARS-CoV-2 and related coronaviruses, as well as one small animal model study, suggest that recovery from COVID-19 might confer immunity against reinfection, at least temporarily. However, the immune response to COVID-19 is not yet fully understood, and definitive data on post-infection immunity are lacking. Amidst the uncertainty of this public health crisis, thoughtful and rigorous science will be essential to inform public health policy, planning, and practice. Beyond individual immunity lies the realm of herd immunity, a concept that may be poorly understood by most people. The basic concept of herd immunity is that when a large percentage of the population is susceptible to disease, a larger outbreak can occur. But as fewer susceptible individuals are available, because others have developed immunity, there is a smaller probability that by chance alone a susceptible individual will encounter an infectious individual. Since we don't know how many people have an immune response that leads to immunity, and further we don't know how long that immunity will last, we have to rely on what we know about other human coronaviruses. A chapter on coronaviruses and toroviruses in the 5th edition of Principles and Practice of Clinical Virology states, reinfection of individuals with the same human coronavirus serotype often occurs within 4 months of the first infection, suggesting that homologous human coronavirus antibodies are protective for about 4 months. In addition, there are indications that antibodies to one human coronavirus group may not be protective against infection with viruses from the other human coronavirus group. Cross-protection would not be expected, as the 229E and OC43 virus proteins have very different amino acid sequences. These 229E and OC43 are other regularly circulating human coronaviruses. We can look at some limited data on the seasonal variation and prevalence of the 4 circulating human coronaviruses that we associate with the common cold. Each of them seems to have a 2-year cycle, which likely correlates with an average protection of 2 years. Taking all this information together, along with what we know about SARS-CoV-1 and MERS, antibody protection likely lasts between 4 months and 2 years, so any effect of herd immunity either through vaccination or through letting the virus run rampant through our communities would only last for 2 years. There's been a lot of talk recently about our testing capabilities. We need more tests in order to feel safer for our children to go to school or to return to work. But there are additional issues with testing that I want to discuss here. If the first issue with testing is that we just don't have enough tests, the second issue is that the tests that we do have are not reliable. And this comes down to 2 features of any test, the sensitivity and the specificity. Sensitivity refers to the true positive rate. Of those who are truly positive, what proportion are identified as positive by the test? Sensitivity is an incredibly important metric with respect to diagnostic tests. Specificity is the other side of the coin and represents the true negative rate. Of those who are truly negative, what proportion test negative? This is important for screening tests. Unfortunately, there's usually a trade-off in commercially available tests where increasing sensitivity results in a decrease in specificity and vice versa. An ideal test would have high sensitivity and high specificity. In fact, part of the reason that the guidelines for mammography were changed a few years ago was because they did not have a high enough specificity, and false positive tests were resulting in unnecessary psychological distress and even worse, radical mastectomy. The most common diagnostic test is the PCR. PCR stands for polymerase chain reaction and is a nucleic acid test. Put simply, a sample is added into a solution that contains a protein that will make copies of the genetic material in the solution. This reaction occurs over a series of cycles to amplify the signal. The cycle threshold, or CT, is the number of cycles the PCR went through before detectable RNA was found and acts as an indirect measure of viral load. The more copies of the virus in the original sample, the fewer cycles the PCR will need to go through before enough is made to detect a signal. The sensitivity of the available PCR tests is pretty bad. In fact, many physicians I've talked to don't put much stock in a negative test if someone has all the symptoms. That said, many PCR tests have been developed, and the most widely used test in the United States is the Abbott ID Now, which has a sensitivity around 85.2%, meaning that 15% of those who are truly positive test negative. On the other end of the spectrum are the antibody tests being used for screening. These are either an ELISA or lateral flow assay. Commercial pregnancy tests are lateral flow assays if you want to imagine those. These tests had a fairly high sensitivity, although those who had a more severe course of disease had a stronger antibody response. However, the specificity was pretty low. In this study, in short, they used blood collected in blood banks from 2016 against these tests. Depending on the test, they had a specificity around 85 and 100%. Now, this blood that they used could not possibly have been infected with COVID-19 because this virus hadn't been circulating at that time. So this implies that just because you test positive doesn't mean that you actually have antibodies. There were a lot of questions about testing, most of which I don't have a definitive answer to. Discuss with your doctor about whether or not you should get one, but the results shouldn't change your behavior in any way. I'm not sure how relevant getting tested is to the scientific community. Considering the low specificity, the population level studies that have been done have very wide margins of error when determining what % of the population has been infected. Until there are tests with higher specificity, I'm not putting much stock into these results. People still have a lot of questions about prevention. What type of face mask to use? How long should I disinfect my groceries? How much can I trust takeout food? I'll try to get into a more holistic view of prevention in this section. As we begin to reopen our communities throughout the country and throughout the world, we need to start to understand our own personal level of risk. Unfortunately, we still don't have enough information about the transmission dynamics of this virus to be certain, and there's a lot of disagreement. There are three primary areas of transmission that are of concern. The first are fomites, which are viral particles that settle on surfaces. Many people have asked me about disinfecting mail and groceries. If that's your level of comfort, then go for it. But if you get virus on your hands, you just need to wash them properly to get rid of it. When I go to the grocery store, I avoid touching my face as much as possible. When I come home, I put the groceries down and then immediately wash my hands. Then I put my groceries away as normal. Finally, I wash my hands a second time. And then, when I go to cook, I wash my hands before and after preparing food, as I always did before, and then again before I sit down to eat. At every step of contact with surfaces of unknown contamination, I wash my hands, which prevents the infection. But at no point am I wiping all my stuff down with Clorox wipes. Look, if that's what makes you feel safe and comfortable, by all means, but it is going above and beyond what I want you to be doing, which is just to wash your hands. You'd think I'd get tired of saying it. You'd be correct, but wash your hands. The second mode of transmission is aerosol transmission. These are viral particles suspended in tiny particles of gas that stay in the environment for a length of time. While there have been studies that have found viral particles in aerosol, there is not yet any evidence that they are infectious particles, and while they have been present, they are present in lower amounts than what was expected. This is why surgical masks are incredibly important in a medical setting. Sadly, there's little evidence that cloth masks are protective against infection or spreading it. I don't love the political divide between wearing a mask and not. I'm required to wear one when I'm in a store, and so I do. Unfortunately, we don't have the data to support either hypothesis. However, we do know that the vast majority of infections are occurring inside, and that this is likely related to airflow and air exchange. I'm not worried about people walking or jogging past me when I'm outside. I'm concerned about conversations I'm having indoors in close proximity with other people. Which brings me to my third mode of transmission, droplets. These are viral particles suspended in a liquid medium that exist in the air very briefly, but they quickly fall to the floor over the course of a few minutes. Droplets exist in close contact, within 6 to 10 feet of maximal range. When you hear about the large secondary attack rate in a Washington Inquirer, it's the droplet transmission you're thinking about, not aerosol transmission. This is where cloth face masks may confer some level of protection, although again, it's unclear. If you're going to the park to meet up with friends and have a picnic, this is where I want to see masks being worn. Unfortunately, it's usually the opposite thing that's happening, where people are wearing masks around strangers for short periods of time and not wearing them among their close contacts, with whom they're in contact for a longer period of time. You may recall this diagram from my previous presentation, which depicts each of these forms of transmission. Aerosol transmission is tiny particles, and those are always through airborne transmission. Droplets can be spread either through the air or through direct contact or through indirect contact. Indirect contact are fomites. Direct contact is when you go and shake someone's hand and become infected. Is 2 weeks of quarantine enough? Well, maybe not. Since people can have detectable levels of virus for more than 2 months, it's possible that they can still transmit the virus. But again, the higher viral load occurs earlier on in the course of infection. It is possible that even though people are still detectable, the virus exists in too small quantities to cause an infection, and we just don't know yet. What we can look at is the serial interval. This is the time between an infector becomes symptomatic and when an infectee becomes symptomatic. There are three possible scenarios with a serial interval, and these can only be determined through meticulous contact tracing. What we know about the serial interval predominantly comes from China and South Korea, where massive contact tracing efforts have happened. In the first scenario, the serial interval is larger than the incubation period. This implies that people are only infectious after symptoms develop. In the second scenario, an infector is infectious before symptoms even develop. In this case, the serial interval is shorter than the incubation period. In the third scenario, the infectee develops symptoms before the infector does, resulting in a negative serial interval. SARS-CoV-2 has a shorter serial interval than SARS-CoV-1 had. There is likely a large amount of pre-symptomatic transmission occurring. In a study examining this among 468 confirmed cases in China outside of Hubei province, the average serial interval was 3.96 days, although it was lower among household contacts than non-household contacts. This is actually further proof of droplet transmission, which requires much more close contact than aerosol transmission. This paper estimates that about 12.6% of case reports were from pre-symptomatic transmission. There's a certain level of risk that we all have to take as we begin to go out into our communities. We have to weigh the risks against the benefits. Do I really need to eat in a restaurant, or can I just go to a friend's house and we order in? What do I get out of the experience of dining out that makes it worth the higher exposure? And perhaps your answer to that question is different from mine. I'm cautious about giving any advice with respect to high-risk populations. Is it more beneficial for a high-risk child to attend school with their friends and socialize, or is it more risky for them to potentially get sick? I don't have an answer for that, and either choice has complicated potential outcomes. As a public health scientist, I tend to err on the side of caution. However, given the lack of accurate data, I'm not comfortable with you having to make this decision before we scale up our contact tracing efforts and get a better handle on the transmission dynamics. The same goes for adults who need to make decisions about doctor's appointments, for example. I'm more comfortable with an individual going to a doctor's office, especially where they'll be given a surgical mask to wear. But we just don't have the data to predict if there are times of the day or week that are less risky to go about your business. I wish I had better answers. I could have better answers with better data, but right now I just don't. There are a number of ways that you can help your community, and this is a common question that I've been getting from people. For those of you who live in New York, the New York Blood Center is accepting donations for convalescent plasma. Check out their website for more information. Furthermore, you can check out your city or state Department of Health webpage for additional ways that you can help. You can also contact local churches and not-for-profits for volunteer opportunities to help out in your community. And you could also check in with your elderly neighbors or other people who are isolated, but make sure to practice extreme caution with these more vulnerable populations. Now, the overwhelming majority of questions I received this round of Ask Mike about COVID-19 were about what to expect in the near and distant future. While there are no clear answers to any of these questions, I suspect that it will be helpful to many people to know that others are asking similar questions. The more general questions surrounding planning future events and when people can see family again. I suspect that once restrictions are lifted, many people will remain cautious about re-entering the world, and I'm not sure how long people are going to be wary about traveling or attending large gatherings. I suspect that this will be a big topic for economists and psychologists in the coming months. That is, of course, assuming that we're done with COVID-19, which, as you may have guessed from the previous half of this presentation, is unlikely. I won't be attending any large gatherings for a while, and I won't be flying anytime soon. I'm not even sure I want to take an Uber for the rest of the year, let alone hop on the subway or bus. While I'm comfortable with a backyard barbecue with close friends who have been isolating, I'm not sure I'd jump to go visit family, but of course that would require me flying out to South Carolina. With respect to grade school in the fall, I'm not sure what it will look like. This will depend largely on the community and our ability to do contact tracing and testing. According to last week's Senate hearing, we should have access to testing in our schools, but how frequently will these be done? How reliable will the tests be? What level of testing do parents need to have in order to feel comfortable sending their kids back to school? With respect to universities, the University of California system decided last week that the fall semester will be taught remotely. I suspect many other schools will follow suit. At Drexel, where I teach, I'm hoping that it will be remote because I'm not yet comfortable returning to work. So when does a state know when it's safe to reopen? This is the big question, and different states are using different metrics, but most are relying on how many hospital beds are open, once they reach a certain threshold, they're likely to shut down again to prevent a surge. What we need is a large number of reliable tests, a massive force of contact tracers, and linked data sets for health departments and governments to have accurate, up-to-date information on what the epidemic looks like. Remember, we haven't been trying to contain this epidemic, just flatten the curve so that our healthcare systems aren't overburdened. Any peak simply implies that there are fewer infections this week than there were the following week. What we can see that trends start to increase at any given point in time. It's a question of healthcare capacity and also the capacity of our public health workforce to keep up with contact tracing efforts. A second wave implies that the infection largely disappears. Everyone is referring to the second wave as though it's some sort of characteristic of pandemics. Most respiratory infections follow seasonal patterns because they're mostly spread through indoors, and as people spend more time outdoors, their exposure diminishes. There are many questions we can ask instead. First, will the epidemic go away at all, or will it just continue to cause infections throughout the summer and into the regular flu season? If it does diminish, like most respiratory infections tend to, will it come back in the fall? Or if it does not reappear in the fall, will it come back 2 years from now? All of this depends on the proportion of individuals who've developed an immune response and how long that immune response lasts. It's also highly dependent on how much we've changed our behaviors for the long term. I can tell you that we need to continue to be vigilant, but as we reopen our communities, we need to maintain proper hand hygiene and stay home when we're sick. As a society, we've brushed off respiratory infections because they're not that bad. I'm hopeful that this winter we'll actually see a decrease in influenza-like illness because people have changed their behaviors, and that will certainly have an impact on this epidemic. If there's no vaccine or treatment, we just need to figure out what our lives look like. What do we value? What are we willing to forego to protect those that we love? I'm not a policymaker and I'm not a psychologist, but I'm certain that our society has changed because of this, and hopefully we change it for the better. Finally, several of you wanted me to chime in on the public response to COVID-19. Clearly, this has been used in the political arena, and that, without any sense of irony, makes me sick. We are deeply divided in the United States, and this crisis has only made those divisions greater. I've tried my hardest to remain politically neutral, but it's difficult not to. So, without further ado, my 2 cents. Public health in the United States is relegated to the states in the 10th Amendment to the Constitution, which states, "The powers not delegated to the United States by the Constitution nor prohibited by it to the states are reserved to the states respectively or to the people." While the CDC serves as the federal arm of public health in the United States, much of public health in our country has a much more local focus, since most public health issues aren't ubiquitous. There are a few places you can look for guidance. Either your local city or state Department of Health, or the New York City Department of Health and Mental Hygiene happens to have a great department. Governments have had good control over this epidemic, such as Germany and South Korea, and you can look to them for some guidance. Did the CDC change the death count numbers? Well, in early April, they changed these to reflect both confirmed and probable deaths caused by COVID-19. But death counts are really difficult to organize since many states have different reporting requirements. I don't expect to have good data on the number of deaths this spring until later this year or early next year. But I think that's the point. Although we have free trade and travel across state borders, each state has its own plans for managing the disease as we move forward. Many states are working together to have similar guidelines so data are comparable. I think that this is a strength of our system to allow the local efforts to be targeted to the local problems. We live in an enormous country. The epidemic among meatpacking plants in Delaware and Kentucky will have a different pattern than in the nursing homes in rural Pennsylvania. I have faith in my city's Department of Health and in my state's Department of Public Health. I think that most people understand the gravity of this pandemic. A lot of people are concerned for their futures and afraid for how they'll pay their mortgages and feed their families. People are angry because there isn't a lot of clear leadership. Mistrust of the government, our top scientific institutions, and the media just leads to a whole lot of people who don't know what to believe, and so they fall back on their intuition and beliefs. I get that people are angry. I'm angry, but I'm also still optimistic. Will we see a spike in cases as a result of the protests? Well, it's a good thing that you asked this question 2 weeks ago because we can now look at the data and see what happened. So come along with me on a magical journey through science. On April 15, 2020, an estimated 3,000 people took part in a protest in Michigan called Operation Gridlock. Most of the protesters happened to remain in their vehicles and they jammed the streets, although around 150 people protested on the Capitol lawn. While we see this nice curve in the number of infections here in blue that starts to decline, it starts to increase and get a little wobbly around the time that these protests started to occur. In Connecticut, a rally was held on April 20th against Governor Ned Lamont's coronavirus legislation, demanding that the state be reopened. Hundreds of protesters paraded through Hartford. Hundreds is a much smaller number than thousands. And so in Connecticut, you could see that there wasn't really much of an effect on the number of cases or the number of deaths. North Carolina is a little bit of a different story. Around the 1st of April, they may have started to reach some sort of peak, but that just kept trending upwards. You'd see this sort of in the death data, and then it increases substantially over time. On April 21st, they had a reopen North Carolina protest of about 300 people. Whether or not there was an effect of this on hospitalizations or cases later on is a little unclear because they were on an upward trajectory anyway. In Washington, the Kitsap County Republican Party coordinated an event called Hazardous Liberty Defend the Constitution on April 19th. This event was attended by more than 2,000 people and included speakers such as 3 Republican state legislators. What's interesting here is that Washington State had a peak around April 1st, which started to decline by mid-April. But shortly after this event, which again was attended by more than 2,000 people, you start to see an increase in the number of cases, and you also see that the death rate starts to plateau. Before I end this presentation, I want to thank you all for being curious. I'm humbled that you've looked to me as a reliable source of information. But remember that I'm only one voice, and I can only read so many papers a day before my eyes fall out of the back of my head. Do your due diligence when consuming information about this epidemic. If someone claims to know something for certain, the only thing that you can know for certain is that they don't know what they're talking about. There's still so much uncertainty, and we're going to find out how this all plays out together. It's an honor and a privilege to be doing my part to keeping you, your families, and your friends safe and informed during these incredibly difficult times. And to my friends and family who are community leaders, faith leaders, and teachers, there's only so much I can do as a scientist. You've seen many of the questions asked among my social circle were about what the future holds. We need leadership, and we need to feel connected even if we can't be together in physical space. This is your time to shine and to help shape the future of our society. Like many companies remind me in their daily emails, we're all in this together, and that's the only way we're getting out of it. I'm with you.